All right. Hello, everyone. Welcome. Um, Welcome to a Rafael Medina cardiology case discussion. My name is Maddie, and I'll be facilitating the session today. I'm super excited for the case discussion today. We have two really exciting guests. So first, as our case discussant, we have Maya Dassanayake, who recently finished her cardiology fellowship at Emory and is now an attending at the University of South Carolina. So Maya, thank you so much for being here. I was wondering if you could kind of introduce yourself a little bit more and share a little bit about your interest in cardiology.
Sure. Well, thank you very much for inviting me to be on this. I'm very excited to hear about the case and to talk about that with everyone. I'm Maya. I'm from Michigan initially, grew up there, did a lot of my medical training there at University of Michigan in Wayne State and Detroit, and then came down to Emory for a great experience in the cardiology fellowship program there and just finished. So I will just be starting my first foray into attending hood in about a month. So should be an exciting transition. But thank you again for inviting me.
Amazing. And I'm curious, is there a specific aspect of cardiology that you're interested in focusing on in your career?
Yeah, I actually have a specific interest in cardio obstetrics. So a lot of my final year of fellowship was geared more towards like women's cardiovascular disease and hypertensive disorders of pregnancy. So that's something I plan to focus on in the future.
Amazing. Well, thank you so much for being here. And our case discussant today is Nidhi Patel, who is a PGY2 internal medicine resident at Emory. Nidhi, thank you so much for being here and for presenting a case, and would love to learn more about kind of any hobbies you have outside of medicine, and also would love to hear how your PGY2 year is going so far.
Sure. Hi, everyone. I'm Nidhi, a newly minted PGY2 at Emory. I'm so excited to be here with you guys and share this case. My hobbies, I've actually been doing a little bit more of painting recently, and I just signed up for a salsa class, so that's on my docket for next week. And I'm really excited. I think that I'm planning on applying into cardiology, and I'm also interested in women's health and prevention in cardiology.
That sounds so fun. I feel like you're doing PGY2 right if you're signing up for a salsa class and doing all those fun things. So that's awesome.
Agree.
Yeah. All right. So we can jump into the case. So Nidhi, whenever you're ready, you can share the first aliquot.
Okay, great. So for the first aliquot, we have a 44-year-old male. He was admitted to the HEMOC service for acute myeloid leukemia, and he was transferred to the
I am so
ICU.
sorry, so sorry. My computer started to lag. One second, sorry.
Oh yeah,
No
no worries.
problem.
No worries at all.
We'll wait for you to share your screen, and then Nidhi, if you don't mind, kind of starting from the top, and then
Sure.
we'll write as we go.
Sure. Andrea, whenever you're ready, just let me know.
Okay, I'm ready. Sorry about it.
No worries, Andrea. Okay, so we have a 44-year-old male. He was admitted to the hematology oncology service for acute myeloid leukemia. He was transferred to the ICU for worsening tachypnea and shortness of breath on day 2 of his hospitalization.
Perfect. So maybe we can pause here. We just have this one liner, but Maya, I really want to hear from you as a cardiologist. How do you think about shortness of breath, and how does the patient's, history of AML affect that differential?
Yeah, so great question. I mean, I think at the end of the day, shortness of breath, dyspnea has such a wide differential. And I think what's really important as a cardiologist is to make sure that you're not just so focused on this has to be coming from the heart. So to make sure that there's been a very broad workup to rule out any intrinsic pulmonary etiologies. And sometimes it's a mix of both pulmonary disease and cardiac disease. So You know, kind of right off the bat, when I start hearing about dyspnea, you want to start thinking about, is there some sort of underlying cardiomyopathy, particularly with cardio-oncology patients? That's something that comes up a lot. So you know, you want to rule out things like heart failure. And then, of course, malignancy also increases your risk of PE. So already I'm thinking like PE might also be on my differential, particularly in the patient who's also tachypnic as well as dyspneic. But like I said, overall, a pretty broad differential. So, but starting to think about heart failure and PE right off the bat.
Great, thank you. All right, Nidhi, we can take it to the next aliquot and get more information.
Sure. So as I mentioned, he just has new onset AML. So there's already a little bit more to his story before he came in. So I'm gonna rewind back about 3 weeks. So before he presented at Emory, he actually first presented to another hospital. And that was for 2 months of progressive leg swelling, abdominal distension, and shortness of breath. So when he first presented to the other hospital, they actually thought based on his labs, he had sepsis, he had leukocytosis, he had some altered mental status. But at the time, they got some imaging and they got a CT abdomen and pelvis. And that showed massive hepatic splenomegaly, which was suspicious for malignancy. They weren't able to do a bone marrow biopsy at that hospital, so he was transferred to Emory. And ultimately, the biopsy at Emory resulted as AML. So this admission that we're talking about is while we were waiting for the biopsy results. So it's day 2 of admission. They got the bone marrow. We're waiting for the results. And he had a rapid response called while they were doing the workup. And that was for worsening tachypnea and increased work of breathing, requiring 5 liters of supplemental oxygen. The only other information we had at the time was a rapid chest X-ray, and that showed that he had bilateral pleural effusions.
All right, great. So we can pause here again, Maya. And what's going through your mind now that we have a little bit more information in the HPI about what could be going on with this presentation?
Yeah, so I mean, certainly when you're thinking about things like heart failure and volume overload, he clearly, with the leg swelling and abdominal distension, clearly that also raises red flags for volume overload and heart failure. I think in particular with the hepatosplenomegaly, even in the setting of AML, I'm also thinking potentially more so not just isolated left heart failure, but right-sided heart failure as well. When we think about right heart failure, we're of course thinking about jugular venous distension, lower extremity edema, and that abdominal distension in particular. That hepatomegaly could also be from even like the appearance of cardiac cirrhosis, where you have enough congestion in the liver that you can have that overt hepatomegaly. So I think this is kind of, and the bilateral pleural effusions on the chest X-ray, of course, also raises your suspicion for both left and right-sided involvement. So again, leaning more towards heart failure, I think at this point. And, you know, even with the outside hospitals evaluation, thinking this gentleman may have had sepsis, patients with decompensated heart failure are also more prone to infection at the time of their hospitalization for heart failure. So these things don't necessarily occur in isolation, right? He may have some underlying cardiomyopathy that may have predisposed him to an infection at that point as well. But sorry, I'll let you all continue and then we can continue from there.
Yeah, and actually before we go forward, I had a quick question. So you were talking about kind of the signs and symptoms that are consistent with left versus right-sided heart failure. And, you know, we have this HPI and kind of thinking as early stage trainees, what types of questions would you say are kind of like highest yield or kind of related to higher likelihood ratios when figuring out, is this heart failure or something else?
Yeah, I mean, I think asking about a timeline for symptoms is really important to me. So like acute onset dyspnea kind of makes me think more of that. I mentioned PE earlier. So that kind of that comes to mind more quickly when you think of something like PE, or when you think of something like acute onset dyspnea. When you're thinking of a more subacute onset, that is more likely to be gradual volume overload and heart failure. You can still have acute onset dyspnea in the setting of like flash pulmonary edema. So if someone has a like acute rise in blood pressure and they're, they have decreased cardiac function, either left or right sided, that can present with more acute symptoms. But I think the chronicity is really important when you're asking about how, when did you first develop these symptoms? Did it progress gradually, or did it occur acutely? I think that's extremely important. And then also, just allowing like free reign for the patient to describe it. I think for pulmonary edema, a lot of patients will kind of describe to me, oh, I feel like I'm like suffocating, or I can't catch a breath. So some of those descriptors, I think, will play a role in narrowing your differential.
Thank you so much.
That answers your question.
Yes, definitely. All right, we can go to the next aliquot.
Okay, so before he was diagnosed with AML, he didn't have any significant past medical history. And then just speaking to the timeline that Maya was talking about, before being diagnosed, he never had any chest pain, never had any orthopnea, no P&D or syncope before. I do have some interesting family history that you guys might want to know. So he has a younger brother who has hypertrophic cardiomyopathy, and he has a maternal aunt and uncle who had sudden cardiac death in their 40s. So I'll pause there.
Yeah, definitely an interesting family history. Of course, that does raise your suspicion for cardiomyopathies that may not be necessarily related to his AML, like hypertrophic cardiomyopathy, particularly in first degree relatives. It's actually, I think, more common than people suspect. It's in about 1 in 500 patients with heart failure might have hypertrophic cardiomyopathy. So I think a little bit more frequent than what we usually think of. And of course, I'm sure everyone's already thinking that at some point they want an echo on this patient. So that certainly will also shed light on what the wall thickness looks like. And then we can talk a little bit more about that as we go into the diagnostic testing. But that family history is already leading you towards what kind of diagnostic tools you want to look at. And just to kind of go back on what we had talked about, like other leading questions, I think what you brought up, Nidhi, like syncope is another important thing to ask patients about, or pre-syncopal symptoms. And syncope, I think, would, if this patient had said, I had a syncopal event like a couple of days prior, that also raises your your suspicion for either something like PE, which is linked to syncope, or arrhythmias potentially being the driver for this cardiomyopathy.
And then going off kind of the family history, when Nidhi mentioned the maternal aunt and uncle with sudden death in the 40s, I'm curious how your mind is thinking about that. Like what types of things are going through your mind when you hear someone who has a family history of sudden death in their 40s?
Yeah, so I mean, that makes so it could be things like, it could be related to hypertrophic cardiomyopathy, but alternatively, even like a dilated cardiomyopathy, patients may be prone to arrhythmias that can lead to sudden cardiac death. I think it's also helpful to kind of, if a patient has more information on what sudden death means, that's also usually helpful. I've had patients say like, oh yes, I had my father passed away in his 40s from sudden death, and then asking more questions, you realize it was a traumatic accident rather than sudden cardiac death. So I think elucidating a little bit of detail if a patient has it is also helpful.
All right, thank you so much. Nidhi, back to you.
Okay, so for this patient's social history, He works as an engineer. He smoked for about 15 to 20 years. He smoked about 1 pack a day for 2 to 3 years, but he quit 1.5 years ago. He drinks 3 to 4 beers every other day. He doesn't have a history of binge drinking. He denied drinking more than 5 drinks in one setting in the last year. And he denied any kind of illicit drug use. He lives alone. He has good family support, and he's able to do all of his ADLs and IADLs by himself.
And we'll probably get to the physical exam pretty soon. So before we hear that from Nidhi, Maya, what are you looking for in particular on this physical exam, and how do you think that would help us make progress on the differential?
So first and foremost, vital signs, right? So you want to know, is the patient hemodynamically stable? And what are you dealing with? Is it, are they hypotensive and tachycardic, or are they, if there's some suggestion of like underlying heart block, if they're really bradycardic? So, you know, I think first and foremost, you really want to know what their hemodynamics look like based on vital signs. And then the exam, I think we don't necessarily, at least for me in residency, I don't think I put enough stock in perfusion status, even more so than volume status on my exam. So, you know, a lot of people learn about like warm and wet versus cold and wet, as far as thinking about things like cardiogenic shock for patients. And, you know, I think what's really important is just putting your hands on the patient and checking, okay, are their distal extremities cool, suggesting poor perfusion? And if so, to what level? Is it to their shins? Is it to their knees? I've had patients who are cold to their thighs and like due to really just poor output. So, or are they warm and volume overloaded, where you might not need to think about things like, you know, inotropes or supporting their cardiac output. So I would say perfusion, of course, vitals and hemodynamics, then perfusion status, and then of course their volume exam. So checking their jugular venous distension, listening to their lungs, and you know, if you hear any rales, that would be pretty compatible with the bilateral pleural effusions on the chest X-ray. Checking their belly. I know we've talked about the hepatosplenomegaly, but also checking for ascites there, could be due to, again, cardiac cirrhosis potentially. And then their mental status also. So are they able to converse with you at all and give you more history? Are they kind of falling asleep, suggesting maybe poor cerebral perfusion? All of that is, I think, very important in examining a patient like this.
Thank you so much. I hadn't really thought about perfusion status as much as volume status. So that was super helpful. Thank you. All right, let's hear the next aliquot, Nidhi.
Sure. So for temperature, this patient was afebrile. His heart rate was 108. Blood pressure was 105/69. He had a respiratory rate of 26. And he was saturating 97% on 5 liters of nasal cannula and 84% on room air. For his general exam, he was sitting up in bed. He did not have any acute distress, but he was mildly tachypnic, and you could see that he had some increased work of breathing. For his neuro exam, he was alert and oriented ×4. He was attentive, and he was able to converse throughout the encounter. For his cardiovascular exam, so just listening to his heart, he had a regular rate and rhythm. He did not have any murmur, did not have any thrills. And related to his perfusion status, he was warm to touch in all of his extremities, including distally as well as proximally. So bilateral knees and elbows were both warm on exam. He did have 2+ pitting edema bilaterally in the lower extremities. And he also had JVD all the way up to his earlobe. For his pulmonary exam, one thing to add for cardiovascular, when we laid him down to 30 degrees, he started getting really short of breath too. Then for his pulmonary exam, he had some increased work of breathing, but no accessory muscle use. And he had decreased breath sounds in his bilateral bases. For the GI exam, He had bowel sounds present. He did have a distended abdomen that was firm, but it was non-tender, and he didn't have a fluid wave. And then for heme, no bruising or petechiae that we noticed.
All right, super thorough exam. Thank you. Maya, curious what's standing out to you?
Well, I think like Nidhi pointed out, so clearly the patient is volume overloaded, but I find it reassuring that their perfusion status is good. And then I think as far as that, the hemodynamics, like blood pressure 105/69, especially in a patient who doesn't have a history of hypertension, is also reassuring. I would say for patients with a history of hypertension on like multiple antihypertensives who are not currently on those, a blood pressure of 105/69 might actually be hypotensive for them. But in this case, I think so far suggestive of kind of a warm and wet heart failure type picture from my standpoint right now. I do think though, still can't rule out things like P, as I mentioned to begin with, just because of this patient being tachycardic and tachypnic and hypoxic. And again, can have sometimes more than one thing going on, although that's not always typical. So.
And one question I'd love to ask you is, so we've talked about kind of perfusion versus volume status and how this person's presentation looks like a warm and wet. And I'm curious if, those four different categories, like the warm and wet, the cold and wet, warm and dry, cold and dry, like if you could talk a little bit about how the management differs depending on which one of those they fit in.
Yeah, definitely. Warm and wet is kind of the classic thing that I would think about with heart failure, where someone comes into the hospital, they're perfusing, so they don't necessarily need inotropic support like dobutamine or milrinone, but you can diurese them with IV diuretics and basically offload the congestion without necessarily needing to deal with contractility. So when we talk about cold and wet, that's when the cold part is really referring to poor perfusion, low cardiac output, and needing to augment that with inotropes like dobutamine or milrinone. And in those cases, I actually typically start inotropes first before even starting to think about diuresing the patient, because if you give them diuretics, but it's not, they're not having perfusion to their kidneys, it's not going to do much. So I usually start by giving them inotropes and then letting them kind of marinate in that for a little bit, and then going ahead to proceed with diuretics soon after. So that's when I think, cold and wet, you start with inotropes, then also diurese. Warm and wet, no need for inotropes, sticking to diuretics. And then when you think about warm and dry, that's when you also want to think about patient where heart failure may not be playing a huge role, and there may be other things like sepsis that is causing massive vasodilation, and that basically warm and dry picture. If you think about cold and dry, those patients can be really, really tricky, and they often need, if it's because of a cardiogenic shock, or if it's because of cardiogenic shock or like low output generally, then those are patients that may need mechanical circulatory support and more advanced therapies right off the bat. I did want to also mention, in the exam, you mentioned the irregular heart rate. It could be that they might have like AFib or some sort of arrhythmia driving their heart failure, but I usually reserve that for judgment for once you actually see the EKG, because patients could, of course, be throwing PACs and PVCs that make you hear maybe an irregular rhythm, but it might just be ectopy as in the setting of heart failure.
That was brilliant. Thank you so much. All right, Nidhi, what information do we have next?
So now we have some labs that we got for the patient. And so we can just start off with a BMP for him. So he had a sodium of 131, potassium of 4.8, chloride of 99, bicarb of 23, BUN 17, creatinine 0.7, And then he had a glucose of 120. For his CBC, he had a white blood cell count of 50,000 and a hemoglobin of 7.5 and a platelet count of 807. And all of these, because this is day 2 of admission, all of these labs are similar to the labs he had when he was first admitted. And then I'll kind of leave it up to the audience to see what other labs that they'd want to order for this patient.
Great. So maybe we can turn it back to you, Maya, and interested to hear what stands out to you about these labs and what you'd want next.
Well, as a cardiologist, troponins and BNP are always a helpful part of the picture for me. So I think those are definitely things that I would want to add here. I think the hyponatremia really goes along with this more heart failure type picture for this patient. And I think as far as other labs that you think about, it sounds like this was like a pretty functional patient to before coming into the hospital or this acute presentation. So I think if you have baseline labs to begin with, like from like any primary care visits or basically any other interaction with the hospital, I think that's always helpful to know what the baseline is for a patient. But I would assume, given the picture that you described, Nidhi, that he was otherwise pretty healthy coming into all of this. So yeah. And did you give the AST, ALT for him yet?
No, I didn't, but both
Okay,
of
yeah,
them,
so liver enzymes would also, obviously help. So go ahead.
both of them were normal.
Okay, gotcha.
But yeah, talking about the baseline labs, he told us that he was like, I had no reason to come to a doctor before this, so we didn't have any baseline labs for him. So his BNP was 230, and then we didn't have a baseline for him. And his troponin was originally 18. This is the high sensitivity troponin, and then it went down to 5 on the second one.
And before we jump into interpreting those labs and next steps, I actually wanted to return to your discussion and like you highlighted the hyponatremia and that it's likely in the setting of heart failure. And one thing I wanted to ask is that, I feel like I had learned that hyponatremia can be like a poor prognostic factor for people with heart failure. And I'm wondering if you could just explain that a little bit more, like why is that the case? And, what is kind of the cardiology insight into that?
Well, I don't know how much insight I can give you into that, but I actually think the nephrologists, we don't give them enough credit sometimes, but they are very also astute, I think, at managing, volume related and hypervolemic hyponatremia. So I think as far as that poor prognosis goes, that, to my knowledge, that's really based on a lot of the studies with looking at tolvaptan as a potential therapy for patients with heart failure and hyponatremia. And I think a lot of those outcomes are related to how severe the hyponatremia is. So it's not basically everyone with hyponatremia is going to have a worse prognosis in heart failure. I think it's really to what degree of hyponatremia do you see in those patients? And I think part of it has to do with how your kidneys regulate salt excretion and reabsorption. And basically, with heart failure in general, you think of it as a there's basically an imbalance of in your renin angiotensin aldosterone system, right? So you are actively working to suppress that system with meds, but part of the dysregulation, I think, is reflected in how a patient's sodium balance, how they regulate their sodium balance. I hope that answered your question.
Oh, definitely. Thank you so much. What would you want next in this patient, given the labs that we have?
Certainly an EKG. I think we already had a portable chest X-ray that showed the bilateral pleural effusions. And then I would also want, an echo to see what their function is both on left and right side. And then also, do they have any underlying valvular disease that can be playing a role in all this?
All right, back to you, Nidhi.
Okay, so we can actually show the EKG, Maddie, and then see if Maya kind of wants to talk us through it.
Yeah, sure.
Can you guys see this?
Yep, I can see it.
Okay, perfect. And Maya, for all of our kind of like earlier stage learners here, it would be super helpful if you could walk us through like, how do you approach EKGs? Like, what is kind of the structured approach you take?
Sure. So I think, in medical school, I feel like they start with okay, give me like rate, rhythm, access intervals. I think it's actually a very helpful, just simple framework for approaching EKGs at any stage. So I think don't write off kind of being systematic in your approach to them. So, looking at the rate for this patient, and then also your, part of looking at my initial scan, I think my reflex from like fellowship and being terrified to like miss STEMIs is first like STEMI or no STEMI. So that is, I think, just a fellowship reflex. But in this case, we'll go through this systematically. So looking at, and I also really rely on that rhythm strip lead to or V1 to tell me as far as rhythm goes what we're working with. So looks like your rate is about 100 and consistent with what we knew from the vital signs. And then rhythm looks like they're in sinus. I see P waves before every QRS on the rhythm strip. So we'll say sinus tach. And then as far as intervals, I mean, you can already see, I think that the big thing that stands out to probably everyone are these big Q waves in the precordial leads. So you can see from V2 all the way through V6, you have pretty deep Q waves here, almost appearing to be like a left bundle type morphology, but not quite. For it to be a bundle branch block, you first want the QRS to be wide enough to be so. So in this case, the QRS is less than 120. So you're going to say this is not quite a left bundle, but you have almost a bundle type pattern and deep Q waves throughout the precordial leads in and sinus tach. So that's how I would start with this. And then I don't, as far as looking for any signs of ischemia, which you have a low suspicion for in this patient right now. The Q waves can be suggestive of that, but I think with a troponin that is, 18 and then 5 in a patient who's not really complaining of chest pain per se, dyspnea, and the overall picture, I think gives you a lower suspicion for this being acute MI.
Okay, perfect. And I was wondering, someone mentioned in the chat, if you could talk through the kind of QT interval and if there's any abnormalities in that here.
Yeah, sure. So, I mean, the QT does look a bit long for this patient. I don't think, let me see what it is. So, yeah, so I think in this case, when you're thinking about, so I'm more worried about like QT prolongation in patients who you're trying to rule out things like long QT syndrome and potential etiologies for wide complex tachyarrhythmias. In this patient, I would say you, I wouldn't necessarily, I would think about, have they received any potential medications that could be prolonging the QT interval, and then try to avoid any that would prolong it further. But otherwise, I would probably want more information before going any further with that.
Perfect. And then last question for the QT interval, is there kind of any helpful tip you have for learners about how we can estimate if it's prolonged or within range?
I do not have any good tricks for that. I typically just count the boxes like everybody else. And then, when you're doing an actual QTC calculation, you really want to take like a tangent from the QRS basically to the end of the T wave. And that's where you really want to count the boxes from. I think sometimes people are not sure necessarily, should they be taking it from the top of the T wave or the beginning of the T wave, but it's really just a tangent to the end of the T wave.
Perfect. Thank you so much for going through that so systematically. All right, Nidhi, I think we can jump through kind of the next pieces of data you have.
Awesome. Thanks, Maya, for going through the EKG.
Problem.
So I'm gonna, before we get to the TTE, which I know you're itching for, I'm gonna give you I'll give you the results of the CTPE. So the CTPE didn't show a PE, it just showed that he had multi-chambered cardiomegaly. So we got the results of the TTE back. So the TTE showed that he had an ejection fraction of 25 to 30%. And starting with the left side of his heart, his left atrium was moderately dilated. His left ventricle was normal size, but it showed a severely increased wall thickness with severe septal thickening. There was concentric hypertrophy, and there was a read on the echo that said that he had what looked like a bright myocardium. His right atrium was moderately dilated, and his right ventricle was normal sized with a normal systolic function. And he had a small pericardial effusion. The only valvular abnormality he had was mild to moderate mitral regurgitation.
Did they comment on any like systolic anterior motion of the mitral valve, like nothing to suggest?
Yeah, so they said no
currently
LV, yeah, no LVOT obstruction, no systolic anterior motion of the mitral valve.
Great. Well, I think we can pause here to interpret the echo findings. And specifically, I'm curious about with this kind of concentric hypertrophy, increased wall thickness, what is your differential for that?
So, I mean, certainly we talked about Hokum with the younger brother, with the history of Hokum, but I think, you know, the septal thickening and concentric hypertrophy certainly raises red flags when it's a patient who doesn't have a history of hypertension, especially. So you always want to put that echo in the context of who is this patient and what is their medical history. And for me, that is, I mean, obviously the low EF is concerning, but the suspicion for hypertrophic cardiomyopathy goes up when you have someone who doesn't have a history of hypertension or sometimes doesn't have other reasons to have thick walls. So there are other cardiomyopathies besides Hokum that will have this concentric hypertrophy with septal thickening. There's like, you know, Fabry's cardiomyopathy can actually also have that thick walled appearance. I think Friedrich's ataxia also, I mean, not relevant to this patient, I think based on the history you gave, Nidhi, but just other things that can also present with a similar type wall thickness. You mentioned the bright appearance of the myocardium. That usually in a report is kind of hinting towards something like amyloid. You might hear about like thick walls plus this bright speckled appearance in the walls. So that can be suggestive of amyloid. Sarcoidosis also has this thick walled appearance, but also has these like kind of random aneurysmal outpouchings and like very basically wall motion abnormalities that don't fit a coronary distribution. So I don't think this echo is necessarily suggestive of things like sarcoid, but I do think it's definitely concerning for hypertrophic cardiomyopathy. The reason I asked about the systolic anterior motion of the mitral valve is, of course, because that's something that we can see in patients with hypertrophic cardiomyopathy and LVOT obstruction. If you know, sometimes you may not see that in the baseline echo at rest, and it's very dependent on, if you have LVOT obstruction, it's very dependent on the loading conditions, right? So basically, if someone has an elevated higher preload or lower afterload, these are things that may bring out LVOT obstruction, or sorry, a lower preload or lower afterload. So just kind of keep in mind, just because you don't have LVOT obstruction on the baseline echo, that doesn't mean that they might not have it with provocation maneuvers. sorry, went a little bit outside of what we were talking about here, Maddie, but
No, this is
I think,
perfect.
yeah, I think the main thing is your suspicion for HCM goes up and your concern for what we call like burnt out hypertrophic cardiomyopathy with the low EF. I think, the small pericardial effusion, I'm not too worried about. It could just be a result of the overall volume overload that we're seeing, and not something that in isolation is a concern.
And I'm curious, so with the EF of 25 to 30%, would you start treatment at this point? And if so, what would you start?
I mean, I think the most important thing in these patients, particularly one who's symptomatic already with significant dyspnea and hypoxia, I would start with decongesting them. So I'm sure probably at this point, the team had already started diuretics for this patient. So, I mean, I think really aggressively diuresing them to start is what you would do until you saw this echo that might be concerning for HOCM. As many of you probably know, when you have hypertrophic cardiomyopathy, you don't necessarily want to drop their preload too much, because that can actually bring out LVOT obstruction and make them worse. So I think like right off the bat, they probably, I would imagine this is what I would have done had I been like seeing the patient before the echo. I probably would have started diuresing them. And then I think with the echo, you probably want to actually be a little less aggressive with your diuretics for this patient. And then you may also, since they're not in low output heart failure, you may want to also start them on, I would actually think about starting them on beta blockers earlier than you would for other patients with heart failure.
Amazing. Thank you so much. All right, Nidhi, back to you.
So yes, Amaya's exactly right. So this patient was started on a beta blocker and diuretics to improve his shortness of breath and his volume overload. And then at the same time, like she mentioned, the bright myocardium. If you look at the note from the cardiologist that day, they say that there's an unclear etiology of why he had the septal thickening, and there was concern that he might also have some kind of infiltrative process at the same time, and that this might not all be due to a potential hypertrophic cardiomyopathy. So Maya, is there a particular imaging test you'd want to order to evaluate for an infiltrative process?
Yeah, so I think as far as infiltrative workup goes, cardiac MRI is a great test to look for what we call late gadolinium enhancement, or scar, basically, that might be more linked to things like sarcoid. There are certain patterns on cardiac MRI too that are suggestive of amyloid. I think, when you're thinking about working up amyloid, you really kind of, you start with the, serum and urine light chains, and then you go ahead with PYP scan to rule out TTR amyloid. But I would probably go to a cardiac MRI directly in this patient, just because it'll help with answering the question of, is this more of a hypertrophic cardiomyopathy picture versus is this an infiltrative disorder? And do you have any scar that you would see there? You can also do things with the echo to get a little bit more information. Like if you do strain pattern on echo, there's certain classic strain patterns that can be linked to amyloid versus hypertrophic cardiomyopathy. So I think that's something that, if you had that information from the echo, that would also be helpful.
Great. And two questions. First is if you could explain what a PYP scan is.
Sure.
And then second, for the late gadolinium enhancement in the cardiac MRI, I'm curious, like, from the MRI, I know that can give you insight as to if there's an infiltrative process going on, but I'm curious, like, from the pattern of gadolinium enhancement, can you tease out what type of infiltrative process it is, like whether it's amyloid or something else? I'm curious what information that can give you.
Yeah, no, that's a great question. So I don't have a lot of experience with looking at cardiac MRI, but from my basic understanding is that there are certain sequences that you can use in MRI, like different types of weighted imaging, that those different sequences can help clarify, does this fit more of an amyloid pattern? Does this fit more of a sarcoid pattern? So I don't think it's necessarily the scar pattern itself with the late gadolinium enhancement. I think it's really different patterns you see on these different sequences that you process the MRI data on. I did see, and then I also did see the question on what is a PYP scan. So PYP just stands for a pyrophosphate scan, and it's basically a type of scan that we use. You use a radionuclide tracer, and it really is looking to see if you have uptake in certain areas of the heart that suggests amyloid.
Thank you so much for that explanation.
Of course. And then I think I missed another question that was in the chat on it might have been for, oh, sorry. It looks like someone was just saying that it's technetium pyrophosphate. So never mind. Continue.
All right, Nidhi, back to you.
So the cardiologists at the time, they were trying to figure out, like, is this just hokum, or is there something else going on? And so they went back to the history. And in the history, the patient had said that he had never had any chest pain, any shortness of breath, any syncope, really any symptoms before he was diagnosed with AML, which is what really drove them to get the cardiac MRI, like Maya mentioned, to evaluate if there was a scar and if there was any other information they could get about an infiltrative process. And they ordered this while waiting for the SPEP and UPEP for the amyloid. So the cardiac MRI showed that, again, he had severe asymmetric hypertrophy of the interventricular septum with a measurement of 1.5 centimeters. And he also had a subepicardial scar. So he had delayed gadolinium enhancement. And the read on the MRI suggested that he might have myocarditis, and it also showed the bilateral pleural effusions.
I actually think thinking back to that EKG with those big Q waves across the precordium, that definitely is consistent with also the finding of myocarditis. You'll have patients who their EKGs look like they've had a big anterior MI when it doesn't add up that they've had an ACS presentation. So that's really interesting about the finding of myocarditis there too.
And before we hear from Nidhi about kind of what happened with this patient, I'm curious if kind of what framework you use to think about the causes of myocarditis and how that could relate to the cause of myocarditis in this patient.
Yeah, so, big differential for things that can cause myocarditis. The big thing that you don't want to miss is something like giant cell myocarditis. These patients present very sick with a lot of arrhythmias, and really the mainstay of diagnosis is a endomyocardial biopsy to make the diagnosis. But giant cell myocarditis is very rare also, but the more common causes are things like a viral myocarditis. So that's something that we saw a lot with COVID over the past several years, a lot of cases of COVID myocarditis. So viral illnesses are kind of the most common, I think, etiology that we run into. But as far as your, workup and how you think about management for it, patients with myocarditis can look very sick, which it sounds like this patient did. So, you really want to have a lower threshold once you have that diagnosis, probably a low threshold to treat with high dose steroids, honestly. I think the conversation, of course, would have to really be had with HEMONC to see if that was consistent with what they would want for the AML treatment and how those two treatment courses would interact. But I would have a low threshold to treat with high dose steroids for patients with myocarditis.
Thank you. And then lastly, before we pass the mic to Nidhi, has given us a lot of information in this case right now. And I'm curious if you could kind of summarize for us how you're framing this patient in your mind.
Yeah, so I would think of this as, 44-year-old gentleman, newly diagnosed AML, presenting with shortness of breath, tachypnea, and volume overload in the setting of systolic heart failure, and in the setting of systolic heart failure, likely due to HCM and myocarditis.
Amazing. Thank you. All right, Nidhi, what comes next?
Okay, so what I didn't tell you guys from the cardiac MRI is that the read on the MRI actually suggested that the myocarditis was secondary to a leukemic infiltration from this patient's AML. But at that time, we still weren't really sure, is this just hokum, or could the infiltration actually be from the cells from this patient's AML? So his clinical course, he was diuresed in the hospital, his shortness of breath and tachypnea improved. He was started on GDMT and he was discharged home. And then he actually started treatment for his AML, and then he had a repeat TTE 1 month later. It still showed that he had this like bright appearing myocardial echo, but he actually had a normal systolic function at the time of 60 to 65% and had decreased thickening of the septum. So I'll let Maya kind of talk it through before I reveal the final diagnosis.
This is a really interesting case. I mean, I think the recovery of his EF is particularly interesting because it kind of suggests that myocarditis was really driving a lot of this, and it wasn't necessarily burnt out hypertrophic cardiomyopathy, especially given that you're saying he's had no cardiac symptoms prior to this presentation. So it really does seem like this was myocarditis driving the whole picture, and then with treatment he appeared to have recovered. So and can you tell me, did they say like what the wall thickness and everything looked like on his follow-up echo?
No, they actually didn't record the wall
Okay.
thickness. All they said was that it was significantly decreased.
I'm assuming significantly decreased may have meant that it no longer, had that asymmetric appearance suggestive of hokum. But I think it'd be interesting to know what the dimensions were relative to the prior echo too. And it could have been that those walls were really thick also in the setting of profound inflammation from myocarditis. So I think the MRI would have clarified that a little bit more, but really an interesting case.
So the final diagnosis was cardiomyopathy from a leukemic infiltration of the myocardium. But because this patient did have a family history of hypertrophic cardiomyopathy, he's actually continuing to follow in the hypertrophic cardiomyopathy clinic to get repeat TTEs to see what his wall thickness is and to monitor it over time. But overall, it's pretty rare to have leukemic infiltration of the myocardium, and there's a couple of case reports out there. There's just one recently published in JACC case reports, and that patient actually presented with a cardiac arrest and had a newly diagnosed malignancy. And when they took a look at her heart, they were actually able to visualize the leukemic infiltration.
You guys should definitely write this up, by the way. I know you don't have enough to do in residency, clearly, but
This is such an amazing case, Nidhi, and thank you so much for really thoughtfully presenting this case. I feel like you were really thoughtful about where you chose to make the pauses, and I just think it made for such incredible discussion. So thank you for all of your work in putting this together during a busy kind of time in residency. And Maya, I wanted to turn it over to you. We have like a few more minutes before we end. Any reflections on discussing this case? And if you wanted to highlight, like 3 teaching points you want learners in the audience to take away.
Yeah, so I mean, I think the value in this case is really to just keep your differential very broad. So I think it's easy to have looked at that echo and been like, definitely hokum, we'll just, diuresis not as aggressively, put on beta blockers and call it there. But I think the biggest teaching point is really to like keep your differential broad and make sure to keep going down the line of diagnostic testing. So that cardiac MRI, I think, was really key in coming up with the diagnosis of myocarditis. And then I think also making sure these are multidisciplinary discussions, particularly with HEMONC in this case, with a, really rare sounding diagnosis of leukemic infiltration. So, I think those are kind of the broad teaching points. The more specific ones, I think, to cardiology are, I think for as far as management goes, don't just assume all heart failure just needs diuresis for volume overload, to really keep in mind that there's certain cardiomyopathies that you can do harm by aggressively diuresing. And then also to, we talked about perfusion status a lot, even though not necessarily relevant in this case. But making sure you keep in mind hemodynamics and cardiac output before you go ahead with the with supporting diuresis for patients. Nidhi, yeah, I really hope you guys are writing this up because it's a great case. I think the other pearls that I saw here was just because a patient is coming in with the new AML diagnosis, don't rule out other sequential results of that diagnosis. So this was all clearly related to his AML and we were, we might not necessarily have thought that from the beginning. So yeah, great, really great case. I'm glad you guys had this one. Learned a lot.
Thank you guys so much. Really, really enjoyed this hour and learned a ton from you both. Cardiology is a little bit less intimidating now.
It shouldn't be intimidating.
Yeah.
Anyone can do it.
Awesome. Well, thank you guys so much and have a great rest of your night.
Thank you.
Thank you, guys. Bye, Maya. Bye, Maddie.